Great. And Anna, I'm hoping you're seeing my screen.
Yes.
Great.
Yes.
So it is now 10 o'clock. Welcome on a Tuesday morning. I appreciate everyone being here. We're going to go ahead and get started. We have a lot to talk about in a short amount of time, which seems to be how one approaches Zoom meetings these days. But welcome to the Behavioral Health Needs Co-occurring with Autism and Intellectual and Developmental Disabilities. My name is David Grady, and I work for the State Council on Developmental Disabilities. I'm the Regional Manager for the Central Coast. Today, as I said, we have a full agenda. We're going to go over a couple of overviews. First, of the developmental service system. These are how services are delivered to people with intellectual and developmental disabilities. Quick definition and review of what intellectual and developmental disability is. Delighted to have Darcy McCann here. She's going to give an advocate's perspective. We'll then focus in on the autism and its diagnosis. Happy to have Anna Fernandez here. She is the clinical director at Hope Services, which is both a behavioral health contractor and a vendor for the regional center and provides therapeutic services through Hope. And closing our today's meeting will be Dylan Alto, who works for a new and innovative service called CalStart, and he'll describe those services and the effectiveness of their approach for people with developmental disabilities and autism. So we do have a huge group. I'm very happy to have such a number. We originally planned for just a few of us and have it be an informal meeting, but we had an overwhelming response, and currently 110 have joined our meeting. So although we do want to keep it informal, we are a big group, so please use your best Zoom etiquette. Mic's off, use those reactions, thumbs up or hand clapping or whatever buttons that are there on the reactions button on the bottom of your Zoom tab. We, as I said, have a full agenda. We have a big group, so we're going to utilize the question and answer feature, which is on the tab of your Zoom toolbar. Please write your questions out in Q&A. Avoid using the chat feature. We're going to try to use chat for the hosts of today's meeting, kind of to communicate back and forth the technical features of today's meeting. So use Q&A and we'll type out answers. Those who aren't presenting will type out answers. If we have time, we will, at the end of our presentation, take questions live. Okay. So the team here that's organized are part of a group called Bridging the Gap, which is a coalition of providers who are dedicated to improving the behavioral health of people with IDD. We have 2 hours, so of course it's going to be an overview, but we are available to work with your clinics, your clinicians, your interns and associates. So please invite us to your supervision, to any rounds, case reviews, to workshops. We're happy to come and discuss cases in detail, go over autism and more thoroughly. And if wanting to, we can maybe whiteboard examples and that sort of thing. So if interested, please talk to your managers and your supervisors and send me an email and we can arrange coming to a workshop. Quickly, I want to talk about this, the place I work, State Council on Developmental Disabilities. We are a state agency that's federally funded, and the tiles here at the bottom pretty much explain what we're doing, which is advocacy, training, all the way through policy shaping. Today, we are doing training and sharing public information, and the goal would be that as you learn from today's workshop, that you gain skills that can affect and improve the system of providing care to people with disabilities. So we recognize that as community-based services are beginning to work more and more with people with intellectual and developmental disability, greater greater awareness of intellectual and developmental disability and autism is required. So quickly, I want to go over what is developmental disability, how does the state of California provide supports and services to people with intellectual and developmental disabilities. The state of California has a proud history of service to these individuals. In the late 60s, a landmark civil rights legislation was passed, a landmark inclusion bill was passed known as the Lanterman Act. This is different than the Petrus-Lanterman Act, which focuses more on mental health. The Lanterman Act is specifically for people with intellectual and developmental disabilities. And primarily what it does is obligates the state of California to provide the supports and services for people with developmental disability to live as independently in the community as possible, while we're getting the services that will help them remain healthy and safe. As I said, this emerged out of the late 60s and has grown. It's been a generation now that this law has been in place. And what has emerged is a very large government administration known as the Department of Developmental Services. And last year's budget was about almost $13 billion, and that is state and federal dollars, and that's a lot of money, about $1 in $20 of the California state budget. Now, the Lanterman Act created a system of service delivery known as the regional center system, which is a somewhat unique system. These regional centers are throughout the state, and they are private nonprofits, much different than how counties operate. These regional centers are not government entities, but are managed by a board of directors. And the term regional center gives that, they are to respond to the needs of the community. There are 21 of them throughout the state, and they are responsible for the service coordination as well as funding the services that are available to people with developmental disabilities. So in the Bay Area, there is the San Andreas Regional Center, the Golden Gate Regional Center of the East Bay, and North Bay Regional Center. Now, the department also is responsible for operating the developmental centers. And when the Lanterman Act was originally written, there were over half a dozen developmental centers throughout the state. And this was the go-to arrangement for a person diagnosed with a developmental disability. If you've ever studied disability history, you know that that the 20th century was significantly, the traditional model was the medical model, and the style of care was through institutional settings known as developmental centers. Since my career started, those developmental centers have slowly closed. There are now just 3, and one in Orange County is de-admitting its residents and moving them into the community. And there are now just 2 small developmental centers that are in operation and are likely to continue. One is to serve the needs of people who have compromised health and are facing issues of aging. That is more of a nursing home setting, and that is known as Canyon Springs. And the other is in Porterville. It is a developmental center set aside for those who've been arrested and have gotten in trouble with the law. And so those are the 2 remaining developmental centers. They're small, and it really is a shift in our generation, and how people receive supports and services for having a developmental disability. So the Lanterman Act is to address all the needs for a person with a developmental disability, but for their educational needs, it is through the federal law, the Intellectual and Developmental Education Act, that organizes and arranges how special education services are delivered. And those services are delivered in public school, and they are delivered from the ages of 3 to usually the age of 22. So it is both through the Lanterman Act and through the IDEA that policies are governed to care for the needs of people with developmental disability. And having this general overview should help clinicians understand of how services are funded and how they're arranged. And so I think it's helpful to get this background. Now, what is a developmental disability? There are several definitions. There's the definition in our DSM-5s. There's a federal definition, but in the state of California, there's a specific definition that that truly shapes how one will end up receiving services from a regional center. This definition is stricter than the two that I mentioned earlier. First, the age of 18 has been identified as the cutoff age for when one can qualify for regional center services. This is an arbitrary number set a little earlier than we know being our developmental period, which can go up to the age of 22 or 25. So they've created this eligibility criteria that ends at the age of 18. A developmental disability is ongoing. One does not get cured of a developmental disability. It's not an illness. You do not need to take medications because you have a developmental disability. It is an ongoing condition that one is to live with. In California, there have been 5 diagnoses set aside to identify to remain eligible for regional center services. One is an intellectual disability, the other cerebral palsy, epilepsy, and autism, which we're going to talk about later. And then there are conditions similar to intellectual disability. So as you see on this list, you don't see Down syndrome. However, most people with Down syndrome will qualify because most likely is because of their Down syndrome will have an intellectual impairment. So that's part A of our definition. And then there is a both and part B of our definition, which is the person must have a substantial limitation in 3 of 7 life areas. And the term substantial is important here. It means the person is unable to do the life activity without extensive support from a direct service provider or extensive training. They're unable to do it. So it's not that one is unable to get their driver's license and unable to drive a car. Rather, it's one is unable to be mobile and has, without support, cannot get from point A to point B. So they would need extensive training for mobility to use the bus system or take paratransit or those sorts of things. So to have a developmental disability in California, in order to receive regional center services, one must have these 5 conditions, begin at the age of 18, and face these the substantial limitations in their life areas. With that said, about 417,000 Californians are receive regional center services. But when you broaden the definition and include the DSM-5 definition or the federal definition that is used to identify students who require special education services, the number of people with developmental disability doubles to almost 750,000 people. So what this means as clinicians that there's a likelihood of working with people with developmental disability. And one of the questions you'll need to ask is, does the person receive regional center services? If they do receive regional center services, you can work in cooperation with the regional center to acquire the services to meet their developmental needs. If they do not, you'll need to be more reliant on community services. So this brief history of developmental services and the definition of developmental disability is to point out that in the course of our lifetimes, we have seen that disability services has moved from an institutional setting to one of inclusivity in our communities. And this is significant, and it's a great step forward in disability in the work that we do. But it also is how one is to provide support. It must be done in a community-based setting. What this means is that regional centers are going to always seek generic community resources first. They're going to depend on what the community offers its citizens in terms of supports and services. That is, the regional center will be the payer of last resort. Before arranging services, they're going to try to find other entities that would provide the service to anyone. And then also in America today, in the United States today, all public policy is shifting toward services being provided in the community, and the elimination of institutional settings as best we can. So because of this, because of the factor that many people with developmental disabilities may not receive regional center services, because regional center is the payer of last resort and does not necessarily will not necessarily provide supports and services for their individuals unless they've exhausted all community resources. Because of inclusion policies throughout the country, and because of current service system challenges, it remains very important that the clinicians and those working in clinical services and behavioral health services have a greater awareness of intellectual and developmental disability. So quickly, I want to just share that we are all experiencing, we're all recovering from the pandemic. And the systems have many systems are going through critical phases where they're trying to meet the needs of the community, but having difficulty doing that. So within the regional center system, there's been some difficulty. The rates remain low, and so it's difficult to acquire and have a professional workforce. The COVID has had a major impact, and also there's been a shortage in housing. And because of the pandemic and closing schools down, there's been an uneven return to special education services. So quite frankly, we are in a period of in our culture where people with intellectual and developmental disabilities are going to require more services and become more dependent on clinicians. So with that overview, I'd like to turn our conversation to Darcy McCann. Let me stop share. Darcy, how are you?
I'm doing well, David. How are you?
Very good. So Darcy, could you describe your disability?
Sure. I have cerebral palsy. I was born with cerebral palsy. I was born premature. That's what caused the cerebral palsy. I was not officially diagnosed until I was 2 years old, though, with cerebral palsy.
And so since you're on Zoom, maybe tell us about the limits to your mobility, those sorts of things.
Sure. So I'm actually impacted by my cerebral palsy in a pretty significant way. Intellectually, it does not stop me. However, physically, I'm not able to do anything for myself. So I depend on supportive living as well as regional center supports to help me with every aspect of my life. But once I'm up and around, I'm able to really give a lot to my community.
It's a great example. You do have a case open at Regional Center.
Yes, I do.
Right. And no cognitive impairment.
No cognitive impairment.
Which enables you to continue with your education.
Yes.
But you do receive both community services that I described earlier, in-home support services. Is that correct?
Yes. Along with regional center services.
And along with regional center services. So yeah, you're an example of how the system is to meet the needs, to meet your needs, right?
Yes.
Okay. So can you give us a little background of, since you're going to Fielding and getting a clinical psychology degree, can you tell us a little bit how it has impacted, cerebral palsy has impacted your family system?
Sure. So growing up with cerebral palsy, basically I've kind of defied the odds a lot along the way. People have always told me, no, you can't do this. And I'm like, okay, watch me, I'll just find another way. Yes, it's difficult. I have tremendous support from my parents and my family, as well as friends and a huge host of things that I'm active in my community. But I try not to let my cerebral palsy define me.
Yeah, you've done a great job of that. You've become quite an advocate in our system, and we appreciate that. But do tell us about how ableism, how you've encountered ableism throughout your
Yeah.
life.
So again, I've experienced a lot of like, no, you can't do this type of thing, or no, you're not able to. When I graduated from high school, for example, um, I went to Santa Barbara City College for a little while and lived in the dorm. So I was able to do supportive living in a college setting that they've never really done that. So they were like, "Oh, she can't do this. She can't live on her own. What do you, huh? There's no way." And I'm like, if there's a will, there's a way, and I will do it.
Absolutely, that's wonderful. And yeah, you meet that resistance from policymakers such as
A lot.
myself. Yeah, yeah, yeah. You can't do it. And the helping profession is somewhat skewed toward ableism, isn't it?
Yeah, especially in mental health type of settings. I feel like some clinicians, they want to talk to a parent or a guardian that maybe would know the individual better, and that's great if they're not able to communicate. But I really prefer like people talk to me directly.
Absolutely. Yeah, that I've had stories of people with cerebral palsy visiting their doctor,
Yeah,
and as the room is being cleaned by maybe a facilities manager at the hospital, the doctor's asking questions to that person instead of the person with the
yeah,
disability. So we've really got
which
to
is just
overcome that.
really frustrating.
Exactly. Anna, I know you have some questions. Go ahead, Anna.
Thank you, Dave. Darcy, thank you for sharing. I mean, these are incredible experience that you are sharing with us. My question is about when you interface with professional, and you already touch a little bit, to receive support, to receive treatment.
Mhm.
Which is the things that help you most? You can say, really, this person is on target in the helping profession, and starting with the positive, and if you can share with us what is the thing that was less helpful that a professional has done to you in your experience.
Okay, so what's really helpful for me, especially with a clinician or professional, would be, again, talk to me, ask me questions. I can answer how I feel or what I'm thinking about a situation, or like how to resolve something. And what's not helpful is people that just assume that I don't feel certain ways, or that I don't understand what you're talking about. I still get that a lot. It's like, oh, she doesn't understand what you're saying. Yes, I do.
Thank you, Darcy. These are amazing points, really, as people that we want to help and treat needs to keep in mind ongoing. So thank you for sharing this.
Dylan, Darcy is in the midst of applying and to soon become an intern at Cal Start Services, but also I know you have some questions you'd like to ask Darcy.
Yes, that's absolutely correct. Hi, Darcy. And you and I have had the pleasure of having lots of conversations on the side, and kind of what even has led us to this point of looking into how you can support our program with some of your work as a crisis counselor and supporting a hotline. I was hoping you can share a little bit about that experience and what that's been like for you.
Sure. Being a suicide and crisis counselor at Santa Clara County really opened so many doors for me. Again, that was another opportunity or situation that basically in the beginning, I met a lot of resistance. People were like, oh, you have cerebral palsy. There's no way you're going to be effective on our line. And so my supervisor, actually my boss, was like, yeah, I was told to give you 6 months of kind of to see if you can do this. Well, I gave them 16 years of service and over 9,000 hours of direct crisis work. So again, in the beginning, it was, oh no, she can't do this. And then I turned out to be like their top volunteer. So
Absolutely amazing. And I mean, it definitely speaks to just the importance of that advocate perspective, right? And really recognizing that experience. And just incredible work. And we're so excited to have you supporting us very soon.
So Darcy, regarding your work as a crisis line therapist, what are some of the, I know you've worked with people with disabilities who've called on the crisis line, and also in just your private life, you've been a support to them as well. What are some of the clinical, the clinical needs that are associated with people with intellectual and developmental disability?
I could think of a couple off the top of my head. One is really important to me, and I hope that, you know, in time that behavioral health will do something to help people with intellectual and developmental disabilities. And that would be, sometimes people maybe need to de-escalate. Maybe they're upset with the staff person because they did something that they didn't agree with, or they didn't want them to do it this way, but they don't really have the words to tell them how they feel. So if there could be a place, actually, I hope that maybe I could design this or help in this way, where individuals can go with a disability and get support that they need. It's not in a hospital type of setting, but a place where, like, they could go to debrief or to do some mindfulness or some stress reduction type of techniques, where not so much they need a hospital, but they just need a safe place to be, where they can be heard and where they can be listened to.
Yeah, and currently, if you receive services for your developmental disability, it's all driven by a program plan with goals and objectives, and it's mostly to improve your ability to live more independently in the community.
Correct.
So it's very regimented, very regulated, goal achieved, intervention, directed, delivered, a goal achieved or not achieved. And what you're saying, Darcy, is can we create a space where one can just be and share their feelings, or even begin to identify with their feelings and begin sharing them, rather than being a patient needing or being an individual needing training. I think that's the point you're making.
Yes.
Yeah. And I think it really brings the point of why we're having today's particular session. So we have a question in our Q&A that I'm going to ask our panelists to see if we can answer as a team. What are the 7 life areas? So I always miss a couple. One is mobility. The other is mobility, communication. We have ability to earn an income, that's financial. Ability to live independently, that's 4. Ability to self-regulate, and I believe that's self-regulate and deal with your everyday, your activities of daily living, that's 5. What am I missing? Dylan, Anna, Darcy? Anybody else have some? So ability to work is a big one. And
Society, Stacy, thank you, Stacy. Yeah, society and contribution.
Yeah. So all those things are those are the 7 substantial limitations, or the 7 life areas where one must demonstrate a substantial limitation. So we are a bit ahead of schedule. So does anybody have a question for Darcy or what we've talked about so far? And feel free to raise your hand and turn on your mics. Devera Jackson.
Thank you. Right, I appreciate you answering my question. And right as you were answering, my computer froze. So I'm wondering if we can kind of put those areas in the chat or somewhere.
Yeah, we'll do the research. I know the reason I don't memorize it, because I have very limited capacity to remember things, so I know where to look for it when I do a Google search. So I'll be sure to add that. Yes, I believe Jose has his hand up.
Yes, I do. David, thank you for the presentation. I work with children, and my experience has been a little bit difficult coordinating with the regional center, and I understand your explanation. You said that actually they are a center for coordination of services. However, my experience has not been effective because they don't necessarily do that. In fact, when I ask for services, for example, ABA for a client, well, it takes a long time. Sometimes it's just passing the buck. Sometimes just like, oh, go to the insurance. The insurance should provide that. Well, I ended up doing it myself when, in fact, they should be doing it. That's my understanding. So a lot of the kids, at the end of the day, they're left without services because of the other aspect. You said that regional centers should rely more on community services first rather than what they offer. However, in general, where are those services in the community? None, at least in my mind. So what to do?
Yeah, that's you have hit your nail on the head. It's why I have a job, is all this need for advocacy. So the answer to your question, you're spot on. The answer to your question is because there's a state law that says that ABA services are to be funded by private insurance, by your medical insurance, then that would be what's known as the community-based service or the generic resource. And so therefore the regional center will push it back to the individual or the family or the instructor, or the clinician, and say, you need to get the service from your private healthcare. Then you go back to your private healthcare, and they're obligated to deliver the service, but the quality of services we're always unsure about. Are they able to face the challenges that are current in our particular world today after the pandemic? So your example about ABA services is spot on, and it is an example of how you would think the regional center would be more responsive to that need, but because of the way the law is written, there are limitations and pushbacks. So I don't know if that's an answer, Jose, but that is the state of things. Exactly. Okay, Kevin, I thought your hand was up, but I see it's down now. Any other questions?
I guess the question I would have for Darcy is, you said that they said because of your disability you couldn't do things. I'd like to have a sense of how that actually was experienced, or was it that flat out that people just said that directly to you, or did they have kind of ways of doing that to kind of undermine the whole situation without being that direct?
I've experienced both. I've experienced where people have flat out told me I can't do something, or someone, thinking that they want to help me would just do things for me instead of allowing me to do them myself. Or so I think over time it's gotten a little bit better, but it happened to me quite a lot when I was younger, going through school, and I always had to say I can do this, or like in my personal life, I was really involved with Girl Scouts, and Girl Scouts for me has been a tremendous organization, but I always had to have my mom or an adult go with me on certain events, because leaders were like, oh, I don't know what to do with Darcy. She just is different. So I think a lot of it's the education, and I think it's gotten better, but I've experienced both in my life.
Darcy, would you think, you've experienced both, yeah, and I think we come from a 20th century tradition of somewhat being insensitive to and use of labels.
Right.
But I think we're now trying to move past, and we're kind of stuck in this unconscious bias period of time.
Yes.
Are you sensing that frequently?
Yeah, a lot of like people, sometimes it just depends on the context. I think it's getting a little bit better, easier.
Great, good. And then we'll take one more question and then move forward. April, your hand's up. Go ahead and ask your question.
Hi, Darcy. Thank you
Hi.
for sharing your story with us.
Sure.
I appreciate it. So I work with children as well, and which includes working with families and parents, caregivers.
Mhm.
And I'm wondering, sometimes the challenge is working with families to help bridge whatever maybe miscommunication or misunderstandings or difficulties that they're having, right? Because both, I'm also a clinician, so mental health and also providing treatment to children and their families. So one of my questions would be, what might be, in your experience, what was helpful, or what would you, I guess, say to parents, that might be helpful to help them to, what might you just share, whether it's a story or whether it's just information that clinicians might be able to take away to share with families?
Okay, that's a really good question. What might be helpful is to allow the child or children to see a mental health professional as early as possible. There are things that come up related to disability or related to being made fun of at school. There's lots of different things that individuals with disabilities face. And I think having a safe, supportive person as a child grows and develops is so critical.
Thank you, Darcy. Dylan and Anna, you might want to chime in on this question too, because it's so important. But April, remember that it's my belief that every family who receives that information that their child has a disability will experience grief and go through a grief cycle. So you have to kind of be prepared for that. The challenges ahead for that family are huge. There might be some denial that the dream of that child to do so well, for the family has to be readjusted, so that the denial element is problematic. The other thing is it's important for these families to realize that children with disabilities are to be, the system is going to, we want to be a system that's going to allow that person with the developmental disability to have the same life that all of us should have, which is to live fully in the community, to pursue relationships we want, to have jobs that we want. So families should have that optimism and realize they're going to have to advocate for their kids as well to move in that direction. And that's where the advocacy component fills in. Anna, what's your thoughts about family system?
Thank you, David. I want to expand a little bit on the grief piece, because I usually use the Kubler-Ross model to assist families to go through the different phases. And there is really everything from the depression to the anger, to the negotiation, to the conflict resolution. But then in the phase of acceptance, all the resources start to roll in a way that is, I want to say, a little bit easier for families, but I've been using the Kubler-Ross model to help them. So I just want to share my experience.
Can I just make a comment that, of course, it affects parents and families, but also the individual with a disability, because especially if you have a sibling or other people that, can, in my case, they can play sports, or they can play on a playground, or just basic things. As a child with a disability, that was difficult for me.
Right.
So like I said a few minutes ago, to also work with the individual with a disability that's facing all these unique nuances that can also support the family to live the best life that they can.
Jeff, we're going to have you have the last question. How are you doing today, Jeff?
I'm doing well. Hi, David. Darcy, can you tell me a little bit? Well, I'm a caregiver for a man who's 44 with a developmental disability, and he's told me many stories about ableism throughout his life, and specifically comments from other people and his emotional evolution over time. Can you tell me a little bit about that and how it affected you then and how it affects you now? And
I think that right now, this is what kind of has led me to want to pursue my PhD to be a clinical psychologist, because I really want to be a clinician and work with people with developmental disabilities and be a sounding board, be an advocate for everyone, because it does, like I said before, I think society has gotten better over the years, but it's, again, I've had to push through so many different barriers, or people, I still get this. In fact, I got this about a week ago. I went out and I was with a friend and they said, "Oh, what would she like for lunch?" And I was like, I could speak for myself. That drives me nuts.
Yeah, good stuff. Thank you, Jeff. Thank you, Darcy. There was one question. So behavioral health is responsible to the case management of ABA. Behavioral health is responsible for medical insurance providers. So it would be a Medi-Cal coverage or your private insurance. Through your childhood, I believe up to the age of, I'm not sure the exact age, but it's through your childhood. I'm going to now share screen. Darcy, we knew you'd be a showstopper, so thank you so much for your presentation.
Sure.
And then Darcy, chime in as we move forward and have points to make.
Okay.
So I'm going to shift now towards developmental disability and the 5 conditions, and then move more toward an exploration of autism. But this slide, very wordy. I don't expect, I'm not going to read it word for word, but these are the 5 conditions. And I think there's some bullet points here about what might be specific toward each of these disabilities, and some thoughts toward how you might consider working with these individuals. Just some thoughts. Cerebral palsy, epilepsy, autism, and even the 5th category does not necessarily mean you can have these issues and not have intellectual developmental disability. You may not have cognitive limitations. Although in many of these cases, cognitive limitations might be a symptom of the disability. So with that, and then the 5th category is very related to the intellectual developmental disability. This is a category that you may be likely to encounter because they've kind of been missed in the system. They may have been, they may not have received special ed services. They may have gone down the truancy track at high school and have gotten themselves in trouble with law enforcement. They might be court ordered to receive care and treatment. So the 5th category oftentimes is that borderline, that oftentimes they are taken as regional center clients and oftentimes are not. And if they are not, it means they've kind of fallen through the gaps and are subject to some of the issues faced by, those in need in our communities. And remember, disability, people with disabilities are a vulnerable population, and as a vulnerable population, they're more subject to abuse and mistreatment and coercion and those sorts of things. So we are emerging from the 20th century, where there was a strong division line between those with developmental disability receiving institutional care for their developmental disability, and those with behavioral health needs and mental illness and behavioral health disorders were to be treated, through psychiatry and that support. And never the two should merge. we've learned as we're now becoming a more inclusive society that, of course, that was an inaccurate way to divide our society. And those with developmental disabilities are definitely likely to encounter behavioral health needs and behavioral health disorders. There's an interesting statistic that the statistics are interesting. They range between 10% all the way to 75%. And I think that's because we go towards 75% when we start talking about the impact of trauma and anxiety on people with developmental disabilities. Quite honestly, the problem of bullying in high school and school is significant, and it definitely affects kids in special education, and oftentimes they, as they enter adulthood, have traumatic needs, post-traumatic disorders. So keep that in mind. It's my opinion, this is an opinion, that when working with a person with an intellectual and developmental disability, you always have to be trauma informed. So as clinicians, it's really necessary to do a differential diagnosis. What is the person presenting that's associated with their developmental needs versus what is the person presenting that's associated with their behavioral health needs? Not an easy task. The two are often merged, but it's significant and important because as clinicians, you want to definitely treat those behavioral health needs and then seek support for those developmental needs. And then, as I mentioned earlier, we had this, we're emerging from a tradition of siloed services. Moving now to autism, I believe we have to kind of do a quick assessment and how much are we being influenced by what social media is telling us about autism. There's kind of this prevailing sense that a person with autism has some extraordinary capabilities. There's a doctor, a surgeon on TV who has autism. Dustin Hoffman in Rain Man was able to count the number of toothpicks that fell to the floor. 60 Minutes does each year some person who's able to play Mozart by ear. And all this is like this kind of mystical knowledge of people with autism. Quite honestly, that is a very inaccurate portrayal. It does not happen with regularity. And those with those issues or those abilities are not necessarily, they may be encountering behavioral health needs associated with their autistic disorder. Autism is a whole person disease. It is just not one that affects one's cognitions or their ability to express language or share emotions. It has, it affects a person's sleep patterns, a number of digestional or gastrointestinal problems, immune system disorders, and then of course some behaviors, some negative behaviors that can lead to them finding themselves in trouble. The sleep disturbance is a significant issue. Oftentimes even young children have insomnia. Moms and dads have to go on sleep schedules to make sure that the child, when awake in the middle of the night, is not getting themselves into trouble with their disruptive behaviors. So that's that. Now the DSM-5, pull it out, good to read. This is the these are headlines from the diagnosis in the DSM-5. And you'll see all these sorts of traits that are experienced by people with developmentalism, with autism. What I want to point out, though, is that remember the DSM-5 really it got rid of the term Asperger's and then moved the understanding of autism to a spectrum disorder, meaning that there are levels of disability associated with autism. Level 3 and level 2, those are the folks requiring the most support. Those are the folks that are going to have those substantial limitations in the 3 life areas. Level 2 and level 3 autism are most likely to receive regional center services. However, as we begin to understand more and more, as neurodiversity is becoming more and more understood, we're likely to start meeting more people who identify as having autism or claim their identity as autistic, but are able to live in their communities, not requiring the same level of support as those at level 2 and 3. These folks too will encounter behavioral health needs and may likely be patients within your clinics or in your practices. So when understanding the autism spectrum disorder, I encourage you not to think of it as linear at all. It's not one is less autistic, level 1, more autistic, level 3. It's not even good to think of it as a series of measures, on a dial where you can kind of tune in where they are in terms of who they are, how they present them, how their autism presents itself to them. The way I like to understand autism is more of a whole person understanding, where it's global and where it just is going to impact the person in all parts of their life differently and uniquely, so that what one might have would be perhaps motor skills are at level 1 or 2, whereas executive functioning, impulse control, ability to manage anxiety might be down to level 1 here. Sensory issues might be at level 2, language here level 1, whereas perception might be a level 2. So every person with autism is going to have a different pattern. This is the truth behind that quote: if you've met one person with autism, you've met one person with autism. So I want to wrap up with some statistics, and then we'll move it over to treatment of autism and other IDD, and pointing out that the autism epidemic is real. This is data pulled from the Autism Society of the Bay Area. This was the number of people identified as having autism in 1987, all the way through till 2020, probably just before the pandemic. And you can see the escalation in diagnoses. This is not due to vaccination. That has been debunked. It is not the reason for autism. And it is not due to improved evaluation tools, although that is a small contributing factor. There are a number of reasons why autism is becoming epidemic in our culture, and I'll go over that briefly in one of my next slides. The number as of 2016 reported in 2020 was 1 in 54 individuals. That's a lot of people with autism. And then, just as we had Darcy and our audience had begun the discussion of family systems, the divorce rate among families with a child with autism is much higher than that of families without children with disabilities. So you can see the impact of autism with these statistics. It's fascinating. Research is growing in terms of why autism is occurring and why it is an epidemic. There are a number of factors that seem to be contributing. One being environmental factors, toxics in our environment, perhaps the use of plastics or genetically modified foods. That's an opinion. No certainty, but there definitely are environmental cues. Genetics seems to play a significant factor, where more twins demonstrate that both will have autism, demonstrates the genetic component. I described nutritional contributions. Interesting research on prenatal factors. The health of the mother while pregnant seems to have some contribution to autism. Particularly immunodeficiencies might be a problematic during pregnancy, and then metabolism issues associated with the child themselves. So much research is going on. None of it is currently definitive, but it's all pointing in a similar direction. And we're very lucky to have in our backyard here in the Bay Area the UC Davis Mind Institute. They have a very generous website with a great series of information, and I encourage everybody who's interested in autism to go to this website and take a look at the videos. They're very approachable videos. look up the resources and follow the research. It's all very interesting. So we are on time. Let me do this. We have a few minutes. We can take one question if anybody has a question. Dylan, any questions in Q&A that might be worth going over?
I have a question, if I could
Yes.
go. My name is Michaela Coates. I'm wondering, I heard you say that there's kind of a undertone in Hollywood and pop culture and social media about autism, and I'm wondering, where do you think that came from? Why do you think that is?
Oh, I'd love to open that up to the audience. People with autism are amazing people. There's an emergence of an autism identity. I believe that those with autism can really help us see new ways of looking at the world. They have unique and incredible points of view. I think there's a fascination associated with that. I would encourage us as clinicians to maybe help us eliminate the problematic behaviors so that the identity can emerge. Dylan or Anna or Darcy, do you have any thoughts about that? I guess not. Edward, I'm going to have to hold off on your question. If you want to put it in the Q&A, and if we have time toward the end, we can maybe answer it then. We're going to stay on schedule, and I'm going to share screen. And make sure if you're not talking or presenting, to have your microphone off. Give me a thumb, or Dylan, if you can point out that the video is working, that would be great. Don't do this.
Video is working.
Clement started counseling with us. He was pretty sad. Both of his parents had died. And he also had a lot of obsessive compulsive behaviors. He was scratching a lot, like there were open wounds all over his arms, face. He had a lot of ritualized behaviors, a lot of staring behaviors. I mean, like, he's a 6'2" guy who stares at you at a supermarket. Like, it would be a little bit intimidating. Plum, do you want to hurt people?
I don't like hurting people.
No, like, what do you want to do to people? You want to
be nice.
You want to be nice. And like, I genuinely think that, like, most people want to be nice. The most important part of any therapeutic relationship isn't the theory I use or the interventions I'm using. It really is the therapeutic bond that we have. And so with Plum, a lot of it was just getting to know him and, like, viewing him as somebody I want to get to know. And then once I had that good relationship, then we could start working on things like me pointing out when things were happening, because he wasn't aware of the behavior. So do you remember when I used to be like, Plum, you're scratching? Yeah, and that used to happen a lot, right?
Right.
Yeah. And then it was, once we got through the awareness of it, then it was, okay, let's find a replacement behavior. Like, the scratching that he had was not an intellectual disability. It was a real sign of a mental health need. We worked on some social behaviors about, like, how long are you allowed to stare at people?
1 second.
1 second. And after 1 second?
I go back.
Yeah, you go back, yeah. And then eventually, once the behaviors were done, then I wanted to address the root causes, which were the grief and loss around his parents. And so we talked first about Mom, and then about Dad.
Right, but I really miss my mom.
I know. And you miss your dad too.
I miss my dad too.
Is it still a little sad?
A little bit sad.
Yeah, that makes sense. It's always going to be a little bit sad. I want to work where the need is greatest. And to me, this is where the need is greatest, because as a gay man, like, I know what discrimination feels like. And it must be incredibly difficult if there's this layer of judgment on you. It's really hard to get away with discriminating against a gay person nowadays, or a Black person, or a woman. It's a lot easier to silently discriminate against somebody with needs. And so when I work with my clients, like, I remember like the humanity that they have.
Well, that video was created in regards to a symposium held a couple of years ago. And I just want to shout out to Anna Fernandez and Hope Services who created that video. Anna, every time I watch that video, I'm so moved. That it's a clear example of what we as clinicians need to encounter. You really saw this, your staff there at Hope really distinguish between the behavioral component of autism versus the emotional component of grief that needed, and both needed treatment. So with that, I'm going to turn the presentation over to Anna Fernandez. Anna and I have become great friends because we're both dedicated to this work. She actually does the work. I just talk about it. Anna, you're the director at Hope Services, the clinical Hope Clinic. I'll have you give the title of your clinic.
Yes, we have a clinic that does outpatient work. So
Yes.
clients come to us to receive therapy and medication and case management. I will tell you more in my presentation.
Yes, and Anna has a unique organization in that it is both a vendor of the regional center and a behavioral health contractor through the County of Santa Clara, which is a good arrangement, a unique arrangement. Other counties do have clinics, similar clinics organized differently, but it is a response to this need that we're presenting today. Anna's clinic is award-winning, and as you can tell, they have some amazing clinicians working there. So I'm going to turn it over to you, Anna, and share your presentation. Thank you, everybody, for putting up with me for the last hour.
Thank you so much. So can you see the screen? Perfect.
Yeah.
Thank you, Dylan, for reassuring us that the audience can see the screen, and thank you for spending time with us today. So as David said, my name is Anna. I'm a licensed family marriage therapist, and I've been with Hope for more than a couple of decades, helping in the clinic, and now I'm the director of the clinic. So I want to talk a little bit about an overview of the mental health treatment. We do some evidence-based treatment, some treatment modalities that are about tips for therapists, the importance of family support, and some conclusion. So thanks to Dave, we really been talking a lot about what is an intellectual disability, what my lens on what I'm sharing with you is more the psychopathology of individuals with intellectual disability, because they arrive to us because they are not at the baseline of behavior. Something more is happening, and they ask our help. And it's important to stress that with the right level of support, really individual with co-current disorder, meaning intellectual disability and mental health needs, can live independent life and be, a great integration in the community. Dave mentioned that the DSM-5, there's been changes in the way we diagnose intellectual disability. So deficit in intellectual functioning, adaptive functioning, and all happened during the developmental period. In the last DSM-4, they were talking about an IQ less than 70. This went away with the DSM-5 to try to be more accurate with our diagnostic means. The people with the intellectual disability are 2% of the general population. It's important to stress that mental illness has been diagnosed on the range of 30 to 40% of this population. So if you have a disability, there is the possibility that you have a co-occurring mental health disorder. And this is 3-4 times more in that in the general population. So we need to be in tune with this need, with this vulnerability. It's important to seek treatment as early as possible. People with disability don't need to suffer for a mental illness. I always say, you know, if you have an intellectual disability, you don't need to feel depressed, anxious, have self-injurious behavior. This is nothing to do with the intellectual disability. It's important to obtain a right diagnosis so family and individual can access the proper support and care. And it's important to utilize the right resources to, again, create health and independence. When a therapist sees somebody with intellectual disability, they come to us and say, oh my God, what I need to do. I mean, it's so difficult. And I am really happy that Dave, you showed the video before this presentation, because Eric really said a lot about which are the 3 ingredients here to try to do a good treatment. And Darcy, you also share your perspective that I really treasure and enjoy. Number 1, use client frame of reference. As therapists, we are trained to jump in the overview or in the view world of the person that we have in front of us, right? And I always say, which is the difference with, you know, giving help with therapy, somebody with an intellectual disability, or maybe an astrophysics that has an IQ that is so out of the normal range, or even somebody with chronic homeless, or some other really important characteristic. We need to do this jump, enter in their worlds. The second is the quality of the therapeutic alliance, because there are many research that show no matter which theory do you use, if the therapeutic alliance is there, your treatment can go far. And I want to show you the multidisciplinary approach that we have in our clinic, because I believe that when you treat somebody with disabilities, a systemic approach, look at the whole person, is really, really important. So look at this model with me. When we treat someone and we conceptualize what is going on, I like to use the HOPE psychosocial model, looking at 4 domains: cognitive domain, behavioral, environmental, and physiological. Cognitive is the way the client think, self-talk, the beliefs. Behavioral is what we can observe. Physiological are all the health problems, the way they react to medication, the sleep pattern, the pain. And environmental, where the client is located. Physical setting, home setting, school setting, extracurriculum activities. When I think about the team, HOPE team that help in this domain, when I say cognitive, I think to all the therapies that we have. Or we really, through therapy, try to understand and possible reframe the cognitive ability of our population. Behaviorally, we have a team of behavioral coach. We have a program that is called TBS, Therapeutic Behavioral Services. Physiological, we have a team of MDs. These are the psychiatrists, the one that prescribe medication, and they check the labs and try to figure out. We also have nurses. And environmental, we have a team of case managers. Our case managers go out in the community and try to link resources for our clients that they need. So this is what happened at HOPE Mental Health Department. We is an outpatient clinic, so we don't have beds, it's not residential, people just comes and go. We have an intensive program, both for children and adults. We have an outpatient program, both for children and adults. We have therapeutic behavioral service for children only up to 21 years old. And as David said, we also have a contract with the regional center, so we can provide assessment, counseling, and medication to clients that are not open under the medical Medicare through behavioral health Santa Clara County. What we do at Hope, we do individual and group therapy. We do medication support with MD psychiatrist. We have the TBS, we have the case management. We use a client-centered approach. We really try to have for each client the treatment that they need. Unconditional positive regards, be there for them, be authentic when we listen to them, be empathic. And in terms of general goal, always think about the growth and the development of the person that we have in front of us, eliminating the feeling of distress due to the mental illness, increase self-esteem, and integration in the community. That is part of our mission statement. People with disability will make community healthier, better, more tolerant. So this is really, really important for us. Evidence-based treatment. I just touched on this. There are many out there, but I want to touch on the ABC model, the trauma-informed care, the cognitive behavioral approach, CBT and DBT, systemic theory, and some other evidence-based practice. So the ABC, antecedent behavioral consequences, is a way to conceptualize what is going on, what triggered the behavior, and how we can help our client to replace the maladaptive behavior with an adaptive behavior and have the consequences that they want. Understanding the trauma-informed care, we need to assume that our population is more likely than not to have an history of trauma. They was telling us how much we know about marginalization of our population, be bullied at school, problem with, wanting to have the life in a certain way, they went in another direction. So acknowledge the trauma is an important part of what we do. CBT model, all of you knows, I think a lot of you know about cognitive behavioral therapy, has been there for a long period of time, but I believe is a strong model to treat our population. Look at how the thought affect the emotion, the feeling, how the feeling affect the behavior. And if you are able to enter in any of this domain, you are able to really ameliorate the mental health situation of your client. As I said before, systemic theory I find extremely useful when we treat our population, because we want to look at the system level. We want to look at the personal relationship, the behavioral pattern, but also how our client is seen from the family, the identified patient, the alliance in the family, the alliance at the system level, group home, administrator, and then at the system of the system, all the regional center, their service coordinator. When we have coordination of care, we want to have everyone around the table because we believe in this system approach. And using a lot of technique like, the questioning and reframing, but main have everyone around the client, and we can do a better job by having this systemic approach. Let me give you now some tips how to provide therapy. Challenges. Sometimes we might or might not to overestimate the comprehension of people with disability, or maybe not estimate. I mean, maybe they comprehend more of what we believe they comprehend. Is a balancing act using client frame of reference. Let's really try to understand where they are. Don't have assumption. Misinterpret behavioral challenge as a psychiatric in nature, may be overdiagnosed. Be careful. Client talk to themselves. Is really a psychosis or is a soothing behavior? You know, try really to see the baseline and then place some behavior in a different kind of conceptual framework. Is a speech the main form of communication? Look at the non-verbal cue. They are very, very important that you put these two things together. I've done therapy to people minimally verbal, using sound tray, using different kind of modality with a great response. Possible solution of these challenges? Use concrete language rather than abstract language. I always say, it rains cats and dogs. Don't say it. Just say there is a heavy rain and you can become wet. Can be verbal or minimally verbal, the person in front of you. So try really to tailor your treatment and your modality to your client, and use a visual aid, communication device, drawing, pictures. You can really do a big difference by using this. Understand this, another things when you provide services, the importance of the cultural sensitivity. Understanding and be respectful in your words, in the way you conceptualize. Listen to understand the perspective of the person in front of you. What does it mean to have a developmental disability in a Latino family? What does it mean to have a developmental disability in an Asian family, in a Caucasian family? There are really layers of understanding a reaction to a developmental disability and a mental illness regarding your cultural background. Can we really hug all these different perspectives and creating a welcoming and inclusive environment? Avoid stereotypes. Not all the Italian like spaghetti and cheese, believe it or not. It's just a joke, but don't assume, stereotypical thinking. And how to talk with people with the intellectual disability, be patient. Be patient, it's okay to slow down. Ask questions that require short answer, concise instruction. Can you do that? And use always a calm tone of voice. Why? Because your client respond to your level of arousal. Especially during crisis de-escalation, it's really important to maintain this inner calmness. And I want to touch a little bit on aggression, because in our clinic, one of the reasons that people come to our clinic is because they've been aggressive. But what aggressive means? Sometimes aggression is a way to communicate. So we know that there is an increased rate of occurrence in aggression in people with the ID and MI, mental illness. Try really to use the model I show you to conceptualize this aggression in the bigger picture. There might be a way to communicate something that we need to understand and address in therapy, or with behavioral modification, positive behavioral modification. So during a crisis de-escalation, I suggest, and this is what we do in our clinic, to direct the client to another activity that is soothing, not to go too much into how you feel right now. Is not the time to ask questions like this. Try to provide a safe environment around the client. You have no idea how many times I went to my lobby and I asked everybody to leave, not the person in crisis, and create a space, a bubble around them, offer assistance, stay calm, and remove stimuli. I have a technique that I want to share with you. I switch off the light in the offices. People look at me and say, why you are doing that? Sometimes even too much light can trigger too much stimuli. And people that talk, stop talking, be silent, remove the light, create a space, create a bubble around. The person, I can tell you, immediately calm down. So, specific tips you can use in therapy. Non-verbal communication is a key to crisis de-escalation. Give the attention, focus on feeling without asking the question, allow for silence. Decrease the sensory overstimulation and speak like me in this moment. If I continue to talk this way, all of you go to sleep, including the person that is overstimulated in that moment, right? This is a little trick that we use. Emergency numbers, suicide and crisis hotline, call 988 is really done for mental health need. There is always 911. There is a parent stress line, a 1-800 number, California Youth Crisis Line, EPS. And for HOPE client, you can always call us also after hour at 408-282-0402. We have a case manager on call that can help you to navigate the after-hour crisis. So the last things I have done, let me see the time. Yes, I'm still. The importance of family support is really crucial. There was a question on family support. Thank you to the individual that asked this question. Family and family are the 80% of caregiver of our people. Dave, in your presentation, you have 60%. I don't know, between 16 and 80, maybe 70%. Sometimes I go in the, so don't take this number exactly, but I want to see the majority are the family that take care of people with intellectual disability. So family care remains the predominant type of care. And it's important that our therapeutic approach are going away to the family dysfunctionality, going more to the how we can support our family, how we can teach their, support them to have ways to take care of the loved one, to take care of themselves, to go through the Kubler-Ross, the 5 stages of grief, to accept and to do the best with this life challenge, but there can be also an opportunity of taking care of somebody with disability. At HOPE, we have a service that is called collateral services, and we can provide support to family to help the person with disability. When you do this very important work, remember always self-care. Self-care for the client, self-care for the caregiver. Physical, mental, emotional, social. Remember to go for a walk. Remember to meditate. Remember to have a journal. Remember to take a break. This time is important. If we don't do that, we risk burnout. So self-care must be part of your treatment, must be part of your life, and must be part of the life of a caregiver. A lot of you take care of, in different role and responsibility. Please, self-care tips are crucial for longevity and sustainability of our work. The regional center help us, the county, Department of Mental Health, Department of Rehabilitation, HOPE Services, START, other providers are there to help us. And in conclusion, and then I will take your question, I hope we can really realize that with available resources and support, individual diagnosed with intellectual disability and mental illness can really live independent lives. I really endorse a multidisciplinary approach when we are doing this kind of work, and really important to reduce stigma. Reduce stigma means allow our client, allow the people that we know to ask for help. And there is a lot of stigma in mental health need. There is a lot of stigma in intellectual disability. We are here to say we can do better. We are here to support, and I hope that we continue to do this advocacy work for our population. Thank you for spending this time with me, and I'm happy to take some questions. Actually, 3 minutes question, right, David? Maybe
Yeah, you
two.
get 3 minutes. No, great questions. A great presentation. Yes, the good cognitive behavioral therapy is proven to be an effective treatment for our community. Dialectical as well. So those are traditional. Those are emerging modalities that are useful. We have any questions from the audience?
David, I actually have a question for Anna directly, if that's
Sure.
okay. My question is I have a lot of friends with IDD, and some of them don't live in Santa Clara County. Most of them do. Are there any other sources of counseling services that you would recommend that take a sliding scale? Because this person has gone through insurance. There's a long waiting list. She doesn't want to involve regional center services, a place like Hope, but wants to see somebody in the community that works on a sliding scale. She also has CP. Is there a list that you can provide, or something I could tell her?
So Darcy, in terms of accessing counseling services, one way is to, if your client or if your friends are open to the regional centers, the coordinator of the regional center, many regional centers, for instance, Hope also work with GGRC,
right?
Also with the regional center of East Bay, and we are trying to reach more regional centers to try to help, because we know that there are not too much specialized services in the community. The second thing goes through behavioral health of the county where they reside. There must be a 1-800 number in order to access services through the behavioral health, so to the county, if they have the Medicare. If these two things do not work, there are professionals in the area that may be able to work, but I want to say it really varies from area to area. If they are in San Diego, there are some. So it is a long conversation to help you, but we can have offline and maybe assist to find resources in the community. There are resources.
Reason we're meeting today is to try to bridge this gap, because it's been so problematic for so many years. However, in the Bay Area, Darcy, Golden Gate Regional Center that has a relationship with San Mateo County Mental Health. The San Mateo County Mental Health has a clinic that works with people with developmental disabilities. So that is through the county. And the same is true over in the East Bay Regional Center. The East Bay, the county, Alameda County has Schreiber Center, which also is a clinic dedicated for people with intellectual and developmental disabilities. But it's hit and miss per county throughout the state. So there's no uniformity at all.
El Puente is another clinic that I know that does this kind of work, but I agree with Dave.
Yeah, Puente is in San Mateo, yes. Yeah. Great. There was a couple of questions on our in the Q&A, a little bit beyond the scope of today's presentation, substance abuse being one of them, how to enroll a person for regional center services, and then those with the children with particular dispositional needs that are difficult to break that channel between for therapy. Those are a little bit beyond today's scope, but this is why we want you to invite us to your clinic so that we can talk about these more specifically. We got two more hands up, and then we'll turn it over to Dylan. Devara, you're first, and then MTS, what a wonderful name. We'll let you go second.
Great, thank you so much. I appreciate it. And thank you all for your presentations. I wanted to ask Anna about, you were talking about trauma-informed care, and I was wondering if you are aware of any other sort of forms of working with folks with trauma, such as EMDR, TF-CBT. Are those things that are those modalities that you have heard of being effective?
Yeah. I am personally familiar with MDR, but we are not using in our clinic. We still use a CBT mainly, and you know, and behavioral modification and what I was telling you. So we don't use this specific approach that you mentioned. But I know that there are some promising practice out there.
Yeah, that's definitely something to do some research on to see if that might be effective. In the video, we had the two walking, and I know that just that being in the environment and walking and the diurnal pattern of walking might be helpful. So anything to intervene that way would be good. And then MTS, let me pronounce your name so I get it right next time.
You said it right. It's Imtiaz.
Wonderful. What's your question?
So thank you, first of all, for this. It's really helpful. So I work in San Pablo, Richmond area with Contra Costa Regional Center of the East Bay, and I'm a pediatrician. I've had a really difficult time getting mental health services for children with autism. And, you know, calling around, most people, as soon as they see the diagnosis of autism for therapy or psychiatric services, say they won't see those patients. So what's the best way for me to advocate for these patients to get mental health services? Is it through the regional center? Are there other agencies? Sometimes I'm just at a loss trying to get help for these kids.
Yeah, well, this is
the
a
regional
huge
center
gap.
of the regional center of East Bay. You can. I hope that the service coordinator. I mean, we can provide remote services. But speaking with the region, with the service coordinator of this family should unlock some possibility, hopefully, for your client. Sorry, Dave, I interrupted.
No, that's good.
Yeah. Sorry.
And Hope, again, is award-winning because of their ability to meet this need. But it truly is one of the remaining gaps. It's where our group is beginning to make effort is, if you're in special education for developmental disability, you're not going to get the behavioral health resources available to other students in the school. It's a big problem. Nobody's really recognizing it. Oftentimes, if a person has autism, the default is, well, they qualify for ABA services. So it's a huge gap. You're really running up against a barrier that you'll need to continue to work through. These sorts of presentations we want to offer more and more frequently, because we need to have the professional community become aware that, yes, you have autism that is improved by ABA services, but then there's the whole emotional component that needs attention as well. So no quick answer for that one.
And Dave, let me add something for the audience at large. We understand that eligibility and accessibility is a challenge. That's the reason why we are here. I wish we can give an answer to solve all the eligibility, accessibility. But I want to say we're really working, and Dave is really leading this effort.
Yes, thank you, Anna.
Really, you are leading this effort, Dave. So a lot of appreciation, but I want to say we are aware that this access and eligibility are big challenge in this moment for our population.
Thank you. And a great presentation. We really appreciate it. Small delivery of applause. And now I'd love to turn it over to Dylan Alto. Dylan Alto has become a tremendous, just been a real joy to work with him. He is new. The California START services are new to California. It is a wonderful method of intervention. And it's something that we hope will take off throughout the state. It's beginning to. I'll let Dylan explain it. On the one hand, it's a regional center-based services, so it's a vendored activity out of the regional centers, but it's got theory that I think is useful for clinicians to think about and clinics to think about when delivering care for people with intellectual and developmental disabilities. So Dylan, it's all yours.
Thank you, David. And thank you everybody for being here. I'm going to go ahead and share my presentation now. All right, let's see. It's a little too small. Can you all see that okay?
Yes.
Thank you, David. So as David mentioned, my name is Dylan Alto. I'm the program director for California START San Andreas. And what I'm going to do now that David has given some insight into autism, IDD, and some of the legislature around that, Anna has given us some insight into supporting folks with IDD and co-occurring mental health, is I'm going to describe a service that we offer, really targeting that specific population of people and some of the pillars that make up this model. I'm going to try and be brief and concise. I also want to call attention to somebody in the audience today. Alex Roth is our clinical director, and she will be kind of watching the chat for me if there are any questions that come up specific to the START model or our program, so that those could be answered in real time, because I know that we are the closing part of this presentation. So as I mentioned, I'm hoping to give an overview of the service itself, as well as kind of some of the methodology that kind of made up this model and how it differs from other crisis services. So on the surface, START is a crisis prevention and intervention service designed for folks with developmental disabilities experiencing co-occurring mental health challenges. This is a model that was developed at the University of New Hampshire back in the 1980s. And it's really an acronym, what START is. And START stands for Systemic Therapeutic Assessment Resources Treatment. And that first word being the most important, systemic. This is a method of crisis prevention in which we work with the system around the individual. So that would include their natural supports like their family, neighbors, people who work with them regularly and have a natural relationship, as well as paid support. So folks who are their mental health providers, their teachers, their other paid supports from the regional center, whomever is involved in that support system. So our goal in doing so is we are hoping to support the development of a crisis prevention intervention plan that's person-centered and outlines how to support this individual when they're experiencing increased stress. We are hoping to also help strengthen the collaboration within the support system. So very similar to Hope's model, we are recognizing that everybody plays a role in supporting this individual, and we're hoping to strengthen the communication and the collaboration amongst providers and natural supports. And really what we're hoping to accomplish in our timeline is to provide some psychoeducation to that support system, as well as the greater community at large, in hopes that they understand the vulnerabilities associated with their diagnoses. So understanding what it means to have autism or to have an intellectual disability and what to anticipate with that diagnosis, and really how we can be supportive in ensuring that we develop an environment that is not inducing stress. Now, I mentioned that we are a little bit different than other crisis services because when most folks think of a crisis service, they think about calling a crisis line. Somebody comes out to provide support, they de-escalate the situation, and then they leave. And while that is one of the services that we have that I'll talk about briefly, our goal is really, our focus is really in the preventative aspect. And so we are using different assessment tools and different methodologies to be able to intervene proactively and hoping that we can mitigate some of those crises before they really occur. So here are some of the core concepts that make up the START model. So we use something called the 3 A's, accountability, appropriateness, and accessibility. So we want to ensure that we are supporting the system and being accountable for their role in supporting this individual. We want to ensure that we are supporting appropriate services for this individual based on those vulnerabilities, and that they have access to all of those services, as well as a fulfilling life. We talked a lot about ensuring that folks with disabilities have access to a fulfilling life, and that really comes back to this idea of PERMA. And I'm going to talk a little bit about that in the second half of this presentation. The model itself is also an evidence-informed model. We use a database, which is the START information recording system, in which we track crisis outcomes, as well as assessment activities to help make informed decisions. It is a trauma-informed model. We follow the World Health Organization's tertiary care model of support. We use a biopsychosocial approach when looking at an individual and trying to make clinical impressions. And it is derived from positive psychology, which is going to be kind of what I focus on today. Now, in a nutshell, these are some of the core services that we can provide as an agency. So we do have that crisis line support to provide crisis intervention. As I mentioned, it is really utilized to support how we can be preventative in nature. So using those crisis intervention situations to help inform the crisis plan that we develop and help prevent it in the future. But we do have that as well. We also have a medical director that is a licensed psychiatrist to help consult with, where we bring cases to consult and discuss, medication reviews, new challenging behavioral presentations, as well as diagnostic clarification. I mentioned the use of clinical assessments. There are several assessments that we utilize, like the aberrant behavior checklist, as well as the START plan, which is an actual START-derived assessment that helps us determine the individual's risk for crisis, as well as the capacity of their care system. And then we also develop personalized crisis plans for every individual that we work with. And these are all, again, person-centered and derived and tailored specifically for this individual. And it outlines things like their expressive and receptive communication skills, the environmental factors that keep this individual operating at their best based on those vulnerabilities, and really how to intervene at each stage of crisis. So just a little visual again of the World Health Organization's tertiary care model of approach. This is the exact way in which we support individuals that we are responding to and working with. Is we try to support them from a primary intervention stage. This is where you have the most impact, right? Providing community trainings, generalized trainings, reaching the most amount of people you can at that primary stage of support. Secondary support would be maybe like our therapeutic coaching service, which is a little bit more targeted and designed to support specific tailored needs that we would want to work on. Say an individual needs some support with communication. We might call on our therapeutic coaching service to help develop some tools that help them communicate with their staff or with their families. So maybe a PEC system or some kind of a tool that can identify maybe their zone of regulation and where they're feeling. And then tertiary intervention is really that crisis support. As I mentioned, we look at everything from a biopsychosocial perspective. So this is really the idea that there is an interconnectedness between the biomedical factors, right? How someone is physically feeling, as well as their psychiatric diagnoses. So the executive functioning impacts of intellectual disability or autism, as well as those social environmental factors, right? So their natural relationships, their access to engaging activities in the community, their ability to feel fulfilled in their, like if they have a job or in some kind of hobby. So all of those things have an impact on an individual's risk for crisis and overall acuity. So recognizing all three of those things and taking them into consideration when we're providing care. So this also obviously takes into account their life experiences and their trauma as well, and how those things can be represented and presented through behavioral challenges. So being cognizant of trauma from the past, as well as things going on currently in their life from a social perspective. So this helps us identify and explain triggers. I'm not going to spend a whole lot of time on this because I could probably talk about this slide for about 20 minutes. But this is the START conceptual model at work, right? It starts with an intake. From there, there's lots of consultation and perhaps some discussion around, what this individual looks like at their best and how to support them. We develop that cross-systems crisis prevention intervention plan, or crisis plan for short, and it is revised over time as crisis situations occur. We look at things like how their other factors could be impacting. So things, we call these moderators. So things like race and ethnicity or cultural identity, how those things can be barriers to service. Perhaps any other kind of environmental factors that could be inhibiting service, and try to support those. And then really by the end of services, which were typically about 12 to 18 months, we're hoping to come to a conclusion of PERMA. And I'm going to talk about that more in just a minute, but this idea that this individual is not only no longer in acute crisis, but experiencing a fulfilling life that is engaging for them and their support team. So that is really when we know we've kind of come towards the back end of our work, is when the support system is experiencing PERMA. So at the end of services, which I mentioned from statistical standpoint is typically about 12 to 18 months. There's definitely a give or take on that. But by the end of that time, we're hoping that this individual and their support system are experiencing some increased oxygen. They're not feeling that level of burnout anymore that comes with consistent crisis incidents and behavioral challenges, that they're feeling more confident in their ability to support this individual and help de-escalate situations on their own. We're hoping that crisis incidents, while we cannot eliminate them forever, are now reduced in severity and reduced in frequency. We're also hoping that they have an increased awareness really of what it takes to support this individual. They have an increased understanding of their diagnoses and the vulnerabilities with it, and they can now support others in understanding how to appropriately work with this individual. Right, and they use that crisis plan that we help them develop well beyond the services and time that we spend with them. So that is a very, very quick rundown of the model. Now I'm going to kind of pivot into one of the pillars of it, which is positive psychology and PERMA. And so as we talked about earlier in the training, Anna took us through some de-escalation strategies and how to support someone who is experiencing stress. We're going to kind of focus on some of the preventative aspects through a positive psychology lens. Now, positive psychology is the idea of enhancing well-being and functioning through a strengths-based approach, right? So trying to get folks to experience more positive emotions, positive thoughts, and overall positive behaviors. So the research on positive psychology indicates that there are significant benefits to utilizing its practices. So this can help somebody feel more courage, more optimism, just an overall happier affect. And there's also medical conditions that could be impacted by really changing the thought process as well. There's research that indicates that there's improved cardiovascular health and improved immune system stability by utilizing positive psychology in someone's life. So really, some of the basic practices at its core are really looking at gratitude and focusing on the positive things that are ongoing in someone's life, because even in the grimmest of moments, there's definitely positive aspects to pull out. So really leaning into those, and also using a tool called reframing, which I'm going to be talking about quite a bit here in the next couple slides. So reframing. Reframing is this idea of taking a concept, a situation, an idea, and changing the perspective, shifting it to in a way that is more positive in connotation, and really focusing and leaning into that side of it, even if it is a rather challenging or negative experience. So what it does is it helps us decrease the negative feelings around a situation or an experience, right? So by doing this, we're taking away that negative feeling and focusing more on a positive emotion. And what that does is it helps us just feel a little bit more fulfilled and a little bit more hope. It helps us identify strengths and the need to live into those to feel the most fulfilled in our lives as we need to, which will help us engage in more positive things as well as face adversity. If we're leaning into our strengths, that's when we have the best odds of overcoming challenges. And in addition to that, that also helps us persevere when we're feeling more hope. So how do we do this? So the first step would be really to try to replace some negative thoughts and lean into some of the positive memories or connotations, or even just moments in a negative experience, right? If somebody, if we're talking to somebody who's having a significant challenge with getting someone to clean up their room, for example, right? And even though we needed them to clean up the entire space, they picked up 2 or 3 items off the ground. That would be a great example of reframing and leaning into that, right? That was a moment where we did see some positivity, we saw some growth, and leaning on that is an opportunity to then lead to more success and lean into some of those some of the moments that we we hope are going to be outcomes long term. But you got to start somewhere. So putting things into perspective, as well as thinking about how this has larger impacts or implications on someone's life. Maybe we can perhaps identify that this doesn't have as big of implications as we thought, right? And so minimizing not the experience, but maximizing the outcome itself. So again, picking things up. If someone didn't clean their room today, there's always tomorrow to do, right? And so in the grand scheme of things, it's really not all that impactful. So allowing mistakes and forgiving others for them, and trying not to engage in all or nothing thinking. So thinking that just because something didn't work out as planned, that there is opportunity to do it again tomorrow and to correct that course of action and perhaps see some more progress the next day. So the last part of that you want to kind of keep in mind when you're reframing is always assuming positive intention, right? Because as communication happens, especially with folks with developmental disabilities who may communicate a little bit differently, or maybe a little bit more direct in nature, we want to recognize that the intention is more than likely going to be positive. If we take that mentality into most situations, we're going to most of the time be right and be able to kind of walk away from a situation with an opportunity to still have a positive relationship. So something else that START focuses on are strengths and strength spotting. So what we lean into is what we call the VIA character strengths. The strengths are the positive parts of your personality that make you feel engaged. And these are the 24 character strengths that everybody has. And we have different levels of each of these strengths. Everybody has some of an aspect of this, but they may be stronger in certain areas than others. And so identifying your strengths and living into them is going to help you boost your confidence. It's going to increase your happiness. It's going to help you feel reduced stress, strengthen your relationships, and also, and also give you an opportunity to overcome some of the challenges that you face. Right, we are at our best when we're living into our strengths, and that's what we want to encourage for the folks that we're supporting as well, is helping them identify what those are and then embedding opportunities for them to live into these strengths and feel fulfilled in their lives. Now, I wanted to give this little visual of just an over and under use of strengths. The strengths are listed on the left side, and maybe some of the language that we'd use when we're either seeing too much of a strength or the absence of a strength are on the right side. And so I want to kind of call attention and connect this back to reframing a little bit for looking at a word like nosiness, right, as maybe an adjective that we would use to describe somebody that could be a little negative in nature. So a way in which we can reframe that is to say that they are curious, right? Or somebody who is, for example, if we called somebody snobby, I mean, that has a very negative connotation to it. They may just be somebody who's in awe, right? Or feeling some confidence in that. Now, something else to think about with some of the over and under use of strengths. So when someone is overusing their strength of bravery or courage, they may be a little, I don't want to use the word oblivious, but not cognizant of some of the danger in the environment, right? We see this a lot with the folks that we support. They're very curious at times. And so they may go into the street with disregard for any kind of safety precautions that they need to take. Another example could be when somebody is very persistent or asking for something that they desire frequently. We may consider that they may present as being obsessive, but really taking it back to the idea that This is a matter of someone being curious, or a matter of somebody wanting access to something that makes them feel fulfilled. So getting back to that root is always the most important part. So lastly, I kind of want to close with this idea of PERMA. And PERMA is also an acronym. It stands for positive emotion, engagement, relationships, meaning, and accomplishment. And this is really the formula to giving somebody a fulfilling life, and really the best form of crisis prevention is somebody who is experiencing PERMA. So the ways in which we can explore PERMA is we want to get folks to feel some positive emotions. So going beyond what they really just need to survive and allowing them to feel fulfilled and happy, right? So giving somebody with developmental disabilities, just giving them access to food, that's a survival need, right? That's not really PERMA. We want to take it beyond that, and let's see how we can embed some of their favorite meals into their meal plan, right? That would be exploring an idea of PERMA. Or even as far as engagement goes, getting people into flow, right? The idea that they are engaged in their activity to the point where it feels very fluid and almost like time is not moving, right? Identifying what those activities are is an important part of crisis prevention, because we want to ensure that folks are having access to the things that make them feel the most fulfilled and happy. And so part of the best way to prevent a crisis from occurring is ensuring that their routine has opportunities for flow. In addition to that, we know the impact of having relationships. Many of the folks that we support have paid supports, but also identifying natural supports in their support system is a huge part of ensuring that they experience PERMA, right? We all need folks to connect with on a social level, as well as feeling love from the people that support us, and the folks that we support are no different. And then same thing, meaning and accomplishment can kind of be grouped in together often. We want to ensure that the folks that we support have an opportunity to engage with their community and do things that are fulfilling. So whether that is working a job or studying a particular subject, we want to ensure that they have access to those things as well. So I know we're a little short on time, David, so I'm keeping that in mind. So the last thing that I want to close with is just kind of leaning on the last things you can do to incorporate a strengths-based approach. So the first thing that you want to do is be a champion, be a model for living into your strengths, right? Encourage folks that we support to do the same. And that starts with identifying what those strengths are. And that leads right into providing education on strengths. So talking about them frequently, right? We're not dismissing the idea that people also have weaknesses, but we are trying to find opportunities for them to live into what they do best, so that they feel the most success and fulfillment as they possibly can. So again, you want to energize folks and uplift them by using opportunities for them to think that they can not only utilize their strengths, but they can grow in other areas as well, right? As I mentioned, those 24 character strengths, we all have access to them at different levels, right? So if they're maybe discouraged by being not as confident in a particular strength, find opportunities for them to build that strength. And that leads right into empowering as well, right? Continue to empower others that weaknesses are not really the way that we want to frame it. It's just an opportunity to build on a strength that's not quite as present. Thank you for everybody. I wanted to make sure we finish in the right amount of time. I know we're butting up right against that, and I want to hand it back to you, David.
Well, just great presentation. It's just such an important, again, when we think about how we delivered care in the 20th century versus the 21st century, what Dylan's talking about, a strengths-based approach rather than a deficit approach, is a sea change. And we as clinicians need to be the vanguard to promote this to our communities, because many of our folks still have corporal models of reinforcement and that sort of thing. So we have a couple of things. One, I'm going to request everybody to complete this satisfaction survey. There's a little bit of I'm required to do it, and we'd love to get your input about how this went. I have a video to show to close today's effort, and then I want to share a quick PowerPoint slide just to remind everybody we are presenting. Close this window. Let's see. We are presenting how, kind of the best practices and care for those with developmental disabilities and autism. But we are in a system that is faced with many barriers and challenges. And I just want to point this out, that many of the points made in the chat and in the Q&A have focused in on some of the challenges you face as clinicians. So part of your skill is to become not only a good clinician, but a good systems navigator, which brings me to our reminder that we are here to offer workshops or clinics. So feel free to send me an invite and we'd be happy to do that. Of course, that's delivered at no cost. And so with that, as you're filling out the survey, appreciate those who are satisfied. It's good to see. Let me also now share a video. So I'm going to stop share. And then we maybe have time for one question as I load up the video. Does anybody have a quick question for Dylan or any of our team?
How do we get the slides?
So I am going to, all of you registered, so I have your email, and I will put the slideshows, and once this video becomes downloaded onto my computer, I will create a link for it and make that available to everyone. Alrighty, so share and play.
I recently saw an article about people with developmental disabilities and mental illness, where it was clearly stated that people with the dual diagnosis are the most vulnerable people in our society. My name is Uday Kapoor. I'm a board member of National Alliance on Mental Illness, and I'm here to talk about Samir, my son. When Samir was born, he had normal toddlerhood. He was walking and crawling and all that, but we noticed speech delays as he approached age 4. And it was later when we had him tested and determined that he had early onset of autism. At the time when Samir was being diagnosed, the science was not very well understood, and he was actually diagnosed as childhood schizophrenia. Because autism was not really coined as a word yet, they were still talking about pervasive developmental disabilities, PDD, or childhood schizophrenia. It was very confusing to us. We didn't understand it. In the beginning, we did not believe it. We were in denial, and we thought this is just temporary and that he will grow out of it. A lot of the burden of diagnosis fell on us as a family. So we had him tested at UCSF, and they determined that he had OCD and also ADD, and as well as Tourette syndrome. And again, there were no remedies, just having to go through as much therapy as possible. So my experience in helping Samir and raising him through all these years, I have developed certain skills where I understand the needs and the pain and the suffering of people like Samir. And it has caused me to have a lot of introspection and how I can help. For people that are attending this symposium, if you can help in any ways you can, and if you are one of the families that is suffering, I sympathize with you and I like to work with you, but we want to bring about massive change. This is one of the most critical factors in our society at this time.
All righty, everyone. Thank you so much for your attendance today. I hope this was helpful. look for the emails of the slideshows, and if you have any questions, please email me, and be sure, if you have an opportunity, invite us to your clinics for us to offer some further training and more discussion about this important issue. Thank you, everybody. Great to work with you today.
Thank you.